I act for clinically vulnerable families alongside Hayley Douglas and Margarita Cornalia, and we are instructed by Kim Harrison and Shane Smith of Slater and Gordon. My lady, I start in the same place as my very first submission before you on behalf of CVF back in 2023. You know what's coming, don't you? It's the CO2 monitor, which I should say is looking very healthy at 844 parts per million, well under the 1,000 which we would need for safety. But back then I was making 2 points. The first one was a practical one about the air quality in the then cavernous, poorly ventilated and very busy room where that first preliminary hearing in Module 3 was held, and the implications of that poor ventilation for clinically vulnerable people, including my clients, who wish to play a full part in this inquiry. The second wider point that I was trying to make was that clean air was of fundamental importance to the inquiry's project, both in understanding how COVID spread, primarily through the air, contrary to scientific and public received wisdom for much of the pandemic, and also in understanding how to make all indoor environments safer for everyone, and especially for clinically vulnerable people. At this final day of the final hearing of the COVID inquiry, I will return to 3 themes which I referred to in my opening. When we say that the past 3 weeks of evidence, and indeed all of the evidence to this inquiry, has strongly supported the need for clinically vulnerable people to have safety, support, and status. Starting with safety. In order to keep the most vulnerable to COVID-19 and other pathogens safe, physical environments must be made safe and more resilient to outbreaks of infectious diseases. Professor Herrick put it very simply: we should all have access to clean air. For clinically vulnerable people and households, the impact of COVID-19 is ongoing. And that's because many indoor environments remain unsafe against infectious diseases, particularly where transmission is airborne. As I said in my opening, clinically vulnerable individuals cannot reliably make themselves safe in indoor settings. The responsibility falls on those who design and manage the environment. The inquiry has looked at in this module a number of different indoor settings, and in each setting the evidence points in the same direction. Clinically vulnerable people were poorly protected then, and they remain poorly protected now. The inquiry, through its recommendations, has the power to do something about that. There's no point waiting until the next pandemic. There's a huge structural challenge which needs to be addressed now if there's any hope that it will be dealt with by the time the next pathogen arrives. In the workplace, the absence of enforceable rights to adjustments which control the risk of infection continues to leave clinically vulnerable people exposed to danger. A number of witnesses in this module spoke of the impossible decision that clinically vulnerable workers had to make between their livelihood and their safety. Professor Herrick said that for people that couldn't work at home, you start to get into the set of impossible risk calculations. And especially if your workplace couldn't be made COVID safe, what do? Do you put yourselves at risk, having previously been unable to leave your house? Or do you decide that actually the risk isn't worth it? And some of the data bears out that many people made the active decision to say, actually, I'm going to leave my job because it's not safe. The TUC witnesses reported about working in a supermarket where nobody followed the rules indoors. If I complained because it wasn't safe, I was the problem. And that is a universal point that can be made about the experiences of many clinically vulnerable people. Professor Nazrou said, there is certainly a large amount of evidence where people have reported removing themselves from work because of their fear of clinical harm. And I asked him about the link between fear and legitimate concerns. And he said, the two go together. So if you're clinically vulnerable, then you are concerned about your health. And if you don't have adequate protections, then those concerns will be amplified. This did not just affect people who were themselves clinically vulnerable, but also people who lived with clinically vulnerable people themselves. Professor Peter Matajic of the Joseph Rowntree Foundation, when discussing the impact of crowded housing, said you'd be stuck at home, perhaps in a crowded accommodation, so you've got higher rates of infection likely. The absence of adequate workplace rules meant that it was in fact a lottery whether you'd be protected or not. Mr. Short of the TUC said, our members were concerned, perhaps members who are not clinically vulnerable or clinically extremely vulnerable, but had family members who were, and were relying on the discretion of an employer or the intervention of a trade union to help them. So yes, more high-level guidance for those situations would have been extremely helpful. Healthcare environments. Professor Shakespeare recognised that clinically extremely vulnerable or disabled people may need healthcare facilities a lot more than non-disabled people. Now, they felt that those very places were places where they would get ill. So, not surprisingly, they didn't go for needed support. And that was a theme which came out very strongly in Module 3 and again in this module. Sam Smith-Higgins of the COVID-bereaved Cymru, a very powerful witness, if I may say so. And I won't do her justice in reading out her quotes, but she said, we were told you can't visit in hospital. Well, why not? Because actually, if you had the right ventilation, you'd have the right masks. There were no issues whatsoever. Hospitals need to be ventilated. You need to bring regulations for air quality inside hospitals, 100%. That needs to be backed up by law. And the same with funerals. Public buildings need to be safe places for people to go. You cannot change the behaviour of people when you can quite easily change the behaviours of the public spaces. And Miss Smith-Higgins said that people should be able to sue if they catch COVID, because of poor ventilation. And your ladyship correctly pointed out that there would be difficulties around causation. That exchange demonstrates an important point. The protection against airborne pathogens has to take place upstream, at source, in the indoor environments where they're most likely to spread. And this has to be through enforceable policies and legal protections, because there is no downstream protection from lawyers who can sue on your behalf when it is, in any event, too late. You have to get the problem at source. The lack of access to healthcare settings applied to mental health too. Dr. Sarah Hughes of Mind said, if you were a shielding individual, it would be very difficult for you to access mental health services. For people with health conditions, physical disabilities, there was an additional layer of structural barriers that they had to experience. And that's one of the themes of this module, is that cross-cutting, intersectional, as it were, issue that arises when you have different barriers that intersect with each other. Cultural settings. Lara Wong said, the failure to provide even minimum accommodation, such as support for those who mask or outdoor events, was exclusionary. For clinically vulnerable people, it's about the right to participate in public and cultural life on equal terms. Faith communities provide online and outdoor services that were particularly useful to vulnerable congregants, but many of those did not continue after the pandemic. Daniel Singleton of Faith Action said it's worthwhile recognising often it was the clinically vulnerable, in particular communities and older people, who were more likely to be frequenting those faith locations. Finally, in the justice system, Charlie Taylor, HM Inspector of Prisons, agreed that clinically vulnerable prisoners would have been particularly impacted by overcrowded prisons because it limited their ability to reduce exposure. And CVF members reported that after online hearings reduced down, there was less flexibility for remote attendance and pressure to remove masks. A theme which unites all of these topics is that stigma and hostility intensify the risks faced by clinically vulnerable individuals. Dr. Sarah Hughes of Mind said, they suddenly became almost like a polarised group of people who often were not just kind of frightened, but in some instances kind of humiliated and mocked for that anxiety in the long term. And all of those factors impacted mental health in the long term. Rivka Gottlieb yesterday said there are ongoing issues today. that could be so easily addressed. Wider access to vaccination, legislation around air quality, these sorts of things, mask wearing in healthcare settings that will protect the vulnerable. These are simple things, but they become so politicised, and this worries me, and the discourse worries me enormously. That discourse is poisonous, my lady, and it hurts people. CVF's second theme is support. Clinically vulnerable individuals and households experience the pandemic's harms more severely and more persistently. But the support response, both during the acute phase and since, did not reflect that reality. Laura Wong's evidence and CVF's 2025 Impact on Society survey, which the inquiry has referred to a number of times in this module, show that risks and barriers such as unsafe healthcare environments, lack of tailored mental health support, weak employment protections, and social exclusion converged with clinical vulnerability. Laura Wong said, for many clinically vulnerable people, reopening was not experienced as freedom. Dr. Sarah Hughes said, we heard from individuals that it felt like a cliff edge, that all of the protective factors had disappeared. Professor Herrick said, rules are easy to follow, but suddenly when there are no rules, it's very hard to make personal risk calculations. When restrictions were lifted, suddenly the idea of protecting others shifted, and it became an advice to people who had previously been shielding to kind of reintegrate themselves into society. For just a few months during the pandemic, the emphasis was on people changing their behaviour to protect vulnerable people. But once shielding ended in summer of 2020, that dynamic changed dramatically. Policy decisions shifted responsibility from systems to individuals in circumstances where people lack the tools to assess their risks and protect themselves effectively. And on that, CVF's third theme is status. There were significant issues at the height of the pandemic around the correct identification of those who were particularly vulnerable to COVID-19. And as the Module 1 report said, the lack of preparation was key. You simply cannot prepare without adequate data. Laura Wong said, our broader message to the inquiry is that because we're not recognised as a group, because the data wasn't collected, we are really limited in what we can say. But we do know for a fact that these experiences were very real and wide-ranging. And this raises an important question. How necessary is it to retain a category of clinically vulnerable people after the pandemic? And the answer is, it's extremely important to do so. The categories of who exactly will be most vulnerable to a new pathogen will vary according to how it spreads. However, clinical vulnerability did not start with the COVID pandemic. All the pandemic did was illuminate something that was already there. There is a core group of people who are consistently at greater risk from infectious disease because of underlying health conditions and weakened immune systems. And indeed, that group will be at risk not just from pandemics, but from other civil emergencies. And that's recognised in emergency planning more widely. And that core group remains vulnerable in poorly ventilated areas. And that's why CVF requests that the inquiry recommends an important step to protect those people. The amendment of the Equality Act to include clinical vulnerability as a protected characteristic. And, in any event, better statutory guidance from the Equality and Human Rights Commission about how clinically vulnerable people should be protected in society under existing rules. To conclude, CVF are grateful to your ladyship for inviting it to participate in 7 of its modules, including being core participants in 4. We thank your ladyship and the inquiry legal teams and the staff in this building for working so hard to make the inquiry a worthwhile and safe process. And I thank the team beside me of hugely committed lawyers, and especially Laura Wong and Dr. Kathy Finnis and the rest of the CVF team who have worked incredibly hard to fight for the people they represent. From CVF's perspective, the inquiry's legacy must be bringing to the fore the challenges which clinically vulnerable people faced and continue to face in playing a full part in society. That clinically vulnerable people will no longer need to carry around CO2 monitors because clean air and other protective measures will become the norm, not the exception. Before the pandemic, clinically vulnerable people were invisible. They must never be invisible again. And we hope that your upcoming reports will ensure that and pave the way for clinically vulnerable people to have the safety, support and status which they need and deserve. Thank you.
Thank you very much, Mr. Wagner. Mr. Freeman, would you rather go after the break or go?